medicine, and various others. Dr. Reuland's responsibilities include oversight of all clinical departments, ambulatory operations, laboratory, and imaging services at the 700-bed medical center. And also, as a corporate vice president in the Johns Hopkins Health System, he also is really a critical component of the integration of clinical activities across the campuses of all of our Johns Hopkins Medicine affiliates. He's also a very sought-after speaker on this topic of building a strong culture of safety and accountability, and really offers a really inspiring perspective. So with that, Dr. Reuland.
Well, thank you so much, Laura and Sally, and all of you for inviting me and including me in this this terrific set of presentations. It's an honor to be here. For those of you who may know me, I actually normally speak in an octave about one higher than this, but I have the flu today, so if I cough and sputter a little, forgive me, but it is my privilege to be here. As a Chief Operating Officer, what I like to say is that I am in many ways the consummate generalist, in that I am privileged to be surrounded by thousands of experts, all of whom know more about their job than I do. And that goes for the security guard and the surgeon and the pharmacist and the safety nurse. All of them are experts in their domain, and my role is to know enough about them to try to set a positive culture and create an environment where they can be effective at what they do. And so I think you'll hear that my comments touch on a number of different angles that we can look at patient safety, and so that's the way I thought I would start this for you today. I'll start, though, very personally, because I think safety is a personal journey, and I'll start with showing you a little about me. And this gets very personal, by the way. For those of you who don't know what a UPJ obstruction, it is a ureteropelvic junction obstruction, and I was born with that. It's a congenital anomaly, and it just means that one of my kidneys doesn't drain as well, or I should say didn't drain as well, and it manifests itself very typically in patients with pain. I am also born with hemophilia B, which is a mild bleeding disorder that generally allows me to live a fairly normal life, except for when I have surgery and significant trauma. And so I have a rule of thumb that says you should never be interesting at an academic medical center, that generally you don't want to be a patient who is interesting to the teams there. But with a UPJ obstruction and hemophilia B, I was decidedly interesting as a patient. And so I, after enduring a couple years of daily pain, went in and did have a surgery to correct this. Now, my surgery was not smooth. It was an open abdominal surgery. I had it done at the Johns Hopkins Hospital and had a rough post-op period right there at my own hospital. I had a significant post-operative retroperitoneal bleed that did require a number of whole blood transfusions. I saw some errors along the way, some of commission, some of omission. For example, I was supposed to have 4 units of fresh frozen plasma. This is the early 90s, by the way, before the recombinant clotting products were available. I was supposed to have 4 units of FFP by midnight that night, and by midnight I had only had 1. My vital signs were not escalated probably as quickly as they could be. And so there were some things going on. Yet I also witnessed incredibly dedicated people. My hematologist, who knew this was a risky surgery for me, was there at 6 a.m. before the surgery and called to the nursing unit at midnight that night to check in on me. So he obviously had a long day and was clearly very dedicated to me, and there were many like him. So it ended fine. I was able to recover, and but I noted that when I followed up later with a long list of things that I saw, many good, some not so good, the response even at our own hospital was fairly fearful, and you could tell that everybody got a little concerned about how much we should talk about this. In the end of it, though, a guy who bleeds too easily was able to have an abdominal surgery that greatly improved the quality of his life. I haven't had any symptoms ever since. And so in the end of the day, it worked fine. But the lesson to me was that clearly there are real issues to fix in any system. And so I saw that in the early 90s as a junior budding administrator. Then, of course, all of us in the late 90s became familiar with the IOM report, and that barely needs much discussion. But bringing it home, this image here of Josie King, many of you may know her story. Peter probably shared it. Peter Pronovost did. But she's a girl who died at the Johns Hopkins Hospital as a result of some mistakes that we made. And the very powerful moment for me as an emerging leader came when I saw Peter Pronovost standing on the stage with Sorrel King, this little girl's mother, describing how the errors at our hospital had caused the death of her daughter, and how we had to take responsibility for that, and how any responsible leader going forward had to recognize that these things can and will happen if your culture and your processes are not managed appropriately. So I had these very personal, very moving things that have always been a part of how I think about safety. But if you fast forward to today, I'll probably broaden this even more and say that we need to think about, when we say safety, who are we protecting and from what are we protecting them? And so the ones that I suspect most on the call are thinking about that we focus on first and foremost are our patients, where inappropriate care, mistakes, gaps in our coordination, I think we all know are significant opportunities for error and harm. And then the spread of infection and the environment of care, though, begins to overlap with our own staff. And so I'm going to talk about staff safety and some issues that we've had there with on-the-job risk and other categories. And then I'll touch on visitors, and then I'll end with a comment about society and kind of how our risk as an industry of overutilization and driving our costs too high actually creates risks in other segments of our society. So I think it's important. I, as an operating officer, think that I operate in a broader context than just the walls of my hospital, and I'll touch on that at the end here. So we've all heard the expression that culture eats strategy for breakfast, and some attribute it to Peter Drucker and some to a man named Mark Fields from Ford. Regardless, I think you understand the concept that culture is a powerful factor in this. But Peter Drucker, I did a little more digging, and he goes on to say that company cultures are like country cultures. Never try to change one, try instead to work with what you've got. So he clearly is indicating that culture is not something, and we all know this, that we change just by virtue of a rule or a statement, that it takes time, sustained effort, and repeated interventions to change a culture. So I would not agree with Peter Drucker that we shouldn't try to change the culture, but I would agree with him that some of our interventions will have to be shorter term if we're going to make some real-time changes. Many of you are familiar with the just culture concepts and of blame, and I think most of us are familiar with Lucian Leape's comment that the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. Yet, sort of balancing that, a chief nursing officer who I know well said, we don't fire people for making mistakes, but we do discipline people for willfully disregarding the rules of their employment, suggesting that there really is kind of a continuum, if you will, of establishing a blame-free culture. And this next image is something that I also borrow from the just culture concepts, and many of you may have seen this, but I think it's a very good way to talk about how we can't really have a blame-free culture. There have to be consequences for people who violate rules knowingly. And on the other hand, we cannot have a punitive culture closer to the one, frankly, that I saw in the mid-90s. We have to find somewhere in the middle there, the one that adequately balances what we're after, and I think that's a clear issue. So when you think about some cultural things that I'll just touch on that we've done at Johns Hopkins Bayview and at Johns Hopkins Medicine overall, number one, we engage the board. Our board members historically, I think, in many organizations have been financial stewards, fiscal stewards of the organization, fundraising, things like that. I personally invited one of our board members to be a CUSP team member with me, to come right onto a nursing unit in 2001. And it was very enlightening for him and for all of us to help him be a part of that. And our board members at all of our affiliate hospitals in Hopkins Medicine overall are much more deeply engaged in our safety issues than certainly they were before. So I think ask yourself if your board is as engaged as they can and should be. I apologize, there's a typo that should say we set a target for reported events. So again, this is probably pretty standard now, but it was not so standard years ago to ask for more reported safety events. And so we asked for 500 events a month at my Hopkins Bayview Medical Center. At the time, we were only getting about 300, 350. We did eventually get to 500 plus, and even got up to 600 for a few months there of reported events. And obviously, these were anywhere from low to high risk through historically the patient safety net, and now through something we call Hopkins event reporting. Hand hygiene, all of us talk about hand hygiene. We discovered the value of an interventionalist. So from a cultural perspective, you had to make it the rule, but this was having somebody out in the culture congratulating people, thanking them, making it a front and center discussion. And we noticed that with that person, our scores were typically in the mid-90s of compliance. And when we had gaps in that person, we would see our results drop by 10 or 15 points. So sustaining that presence we found to be important. CLABSI, I think many of you know the stories there of the checklists and the need for those, and I won't spend a lot of time on that other than to say that in our burn unit, where infection rates were certainly higher at baseline, and where we really all doubted we would ever get them to zero, even our burn unit has had multiple years without central line-associated bloodstream infections, and extremely proud of the team's work for that. We have awards called Patient Safety Stars that I'm sure many of you do, and we talk about safety at every employee forum. So twice a year, the president of the medical center and I each put on the same talk 20 times, different times of the day, different days of the week, and talk to our employees about things that are going on in the organization. And we always start with patient safety as the number one item on there. And then finally, our Armstrong Institute is sort of the embodiment of many of these kinds of things coming together into a structure that really supports the science of safety and advancing it in our hospitals. And so we have a long way to go, but with these ingredients, we feel better positioned to do this. And so the gut check, I think we always have to ask ourselves is, does our culture really support the identification and the reduction of risk? And I think many of us would say, well, yes, it's doing better at that, but I doubt that any of us would say that we have all of this completely licked. So ask yourself, what's the first thing you talk about? On my Chief Operating Officer dashboard, the first issues are safety issues. When do we talk about safety? We talk about safety in every forum that there is. And do you encourage staff and faculty to speak up and speak out, and do they feel safe in doing so? I think we do, but I would tell you that in our organization we are still not at 100% on this, and I suspect many of our organizations on this call are similar in that regard. When you think about strategy, I think there are really two things. So if you have a culture that supports it, now you do need to get to strategy, and for us it's been mostly transparency and accountability. For transparency, are our metrics reported in a timely, understandable, and uniform way? And I'll share some of those with you. And are our leaders accountable? And in our organization, our leaders are required to report on some of these metrics that I'll show you to our boards, and part of everybody's compensation is related to performance and improvement in some of these areas. And so let me show you, this is just a summary, and I apologize that this one doesn't show up well on the slide, but what this is a conglomeration of all 5 of the hospitals in the Central Maryland region. So if you sort of can make out the columns, the first ones are Hopkins Bayview, the first 4 columns, the next 4 Hopkins Hospital, the next are Howard County, our Sibley and suburban hospitals. And then down the side, we have metrics that we share with our boards, and we change the order of these periodically from meeting to meeting, depending on the focus. but you'll see patient experience, you'll see preventable harm, and you'll see efficiency metrics on here. And so what you'll see is just an aggregation of high-level metrics. MHACs are Maryland's equivalent of potentially preventable complications. There are about 60 of them, and all Maryland hospitals are actually incentivized to reduce these. And so you will see that in some of these indicators, as you look down the rows, you will see ovals that have a dollar sign in them that are either red, green, or yellow. And those are metrics for which the hospital's compensation is changed by the Maryland regulatory system. And if it's green, it means that hospital is currently being rewarded for that. Red, it means that hospital is in a penalty or at least a non-reward zone, and yellow is in some bordering region. And so we share these metrics at every board meeting, and all the presidents are required to speak to them, particularly to the ones that are not achieving the targets, but are also encouraged to share the stories with the others about things that are working well. And so this is an example of, I think, really good transparency and accountability that we continue to hone this, by the way. This is something we will change almost on a quarterly basis as we think of new metrics and think of different ways to present this, but we think it's powerful. One of the things we talk about is you think about how rigorous financial reporting is at hospitals, where there typically are finance committees of the board. There are typically multiple meetings and audits and external audits looking for the rigor that required for accurate financial reporting. One of the things that we ask ourselves organizationally is our safety reporting as rigorous as our financial reporting? And for most of us, that answer has probably historically been no. And I would just suggest that for many of us, we probably need to bring that closer. And so, as I mentioned here, we try very hard to make our reporting that rigorous. And Maryland hospitals, I'll just comment a little further. We are fond of saying in Maryland that there are 49 states, and then there's Maryland when it comes to how hospitals are reimbursed. And in Maryland, all 47 acute care hospitals have a significant portion of their revenue at risk for all payers, not just Medicare or Medicaid. But for all payers, we have up to 8% of our revenue at risk for performance on the same kinds of value-based purchasing metrics that most other states have for their Medicare populations. So these are significant issues for us. When we talk about metrics to include on our dashboards, I think is an important conversation to have very transparently. So at our board quality committee meetings, we will talk about which metrics should we include, which have the high impact on patients, which are valid and reliable measures. Sometimes a metric is really important, but only a few people can influence it. That one may not be one you want to share in a large public forum because it won't mean something to everybody. But some of the metrics mean something to everybody in the organization, thinking about hand hygiene and influenza vaccinations, etc. So we encourage a rigorous discussion about what you should even include on that dashboard, and would suggest that that should be a fluid document. And so the gut check for strategy is, do we have a good system of measurement and accountability? If you walk around your hospital, do your managers know their numbers on these important things that we have decided? And I would say that we do fairly well at this, but we are not at 100% on this, and probably anybody who tells you they are is probably not thinking clearly about this, because these are constant challenges to manage. Do your staff feel empowered to develop new processes? And I'll give you some examples of that as we go. And do our physician leaders know their safety and quality numbers? Those are the gut checks that I can try to ask myself routinely, and there's almost always opportunity to improve in that regard. So let me share with you some examples of things that we've done, that some of which will probably feel like ones that you have done, but some may cause a little bit different kind of thought. So let me just start. Medication safety is a clear issue here. Most of us know that that's probably the most frequent kind of event reported. And so a little sub-example of medication safety. We purchased a pill packaging apparatus for our pharmacy, and while that certainly created some improved safety, we noticed it had some risk in itself, that there were times when the packager would put the same pill in twice that it was only supposed to put once, that the label might not be legible for the expiration date, or might crush the tablet, or things like that. And we noticed those kinds of things happening through our event reporting, and took some steps to try to improve that. And with a few tweaks and changes of things, we were able to reduce those rates dramatically, as you can see in the slide. So even once we put a technology in place, we realized that we had to continue to work with that technology to hone it. And I think that's a theme that comes up with our EMRs and other things over time, that just putting it in place isn't good enough. It's our job to continue to hone and manage it closely and optimize it. We also had a group looking at aspiration pneumonia preventions. We looked at a baseline couple of years and had what amounted to about 2 per month of these aspiration pneumonia documented events, and empowered a multidisciplinary group of physicians, nurses, pharmacists, respiratory therapists, and others to really take a look at this. And what you can see is that at baseline, there were some best practices that I think most people who are familiar with this would know, but we were clearly not following those best practices, at least on an initial set of audits that we did of ourselves. And so that was clear opportunity right there to just standardize and audit what we did. So that multidisciplinary group, over the course of several months, put a number of different interventions into place. And I will not describe each and every one of these, but the concept is that as they went through and changed this and that, we went from having about 2 per month in the baseline 2 years before that to only 3 in the past 12 months since this work began, and we're on a 4-month streak of none. So we're probably not done with this, but empowering a work group to just make sure that we follow evidence-based practice alone was a source of risk reduction in the intensive care and other kinds of patients. Falls are obviously one that many of us have worked on repeatedly. This is a story, in our case, of something we call a medical behavioral unit. So this is sort of the highest risk population you could imagine, because these are patients who have both a medical as well as a behavioral issue. And so it's a very specialized unit that over time has had significant issues with falls. In 2013, 295 of 825 documented falls occurred on just that unit. So, more than a third of the falls on the entire campus happened on that unit. So again, a multidisciplinary team engaged in these events, facilitated with some lean management techniques and other kinds of improvements, did these types of bulleted items, and I won't read them all on here, but just to kind of give you a sense of the things that we did there. I did ask them about finger foods. I said, you're going to have to tell me what you did with finger foods. And their answer was, if you just gave people finger foods, it reduced their wandering. And so that was an interesting strategy in and of itself. And what we found was that they really changed the game on that unit. That unit went from having about 295 falls. Excuse me a second, my screen just disappeared for a second. To having 119 in the last 12 months, so a huge reduction in those falls. We did still have some with fracture, and in fact we had a few more with fracture in the follow-up period, averaging 24.6 per month in the baseline to 10 in the last 12 months. So a terrific bit of work done, and they did present this at the Premier conference just a few weeks back. And that led the rest of the campus to change, so that the entire falls volume at the campus dropped to 564 the follow-up period. and has really set the standard for how we can do falls reduction in some of the other units. Now clearly the medical behavioral unit had the largest opportunity, and so it could reduce the most. But we are certainly spreading these techniques to the other units and hope to continue that success. So, medications, aspiration pneumonia, falls, very classic safety preventions that probably many of you are working on. I want to introduce throughput, which is also, in my view, as a chief operating officer, an important part of safety. This is where we're training people to think about the next patient. So in an emergency department, they're used to this. Ask any emergency room nurse or physician who they're most worried about, and it's typically the person who's in the waiting room who they haven't yet gotten to, or the person who's in an ambulance on their way here and they don't know about. And so focusing on the next patient is a cultural shift that takes some work. What this slide is showing you is some lean daily management boards. The left one is from one of our general medicine units, and the right is from our emergency department. And I just show them as examples of how the staff are working with daily huddles on their throughput. And if you look at the left one of our general medicine units has something called the NEDOC score. And I don't know if you're familiar with NEDOC score, but NEDOC is a concept of emergency department overcrowding. And we think it's a real victory that our medicine unit is asking how busy it is and crowded it is in the emergency department as a part of their regular daily huddle. We think we've really gotten somewhere when a medical team is asking about the patients who they don't even know yet. And likewise on the right side, certainly our emergency department working on its throughput has been a real challenge. We've actually had some very focused challenges on my campus with staffing that has led to some very high left without being seen rates, and the team is working on that as we recover our staffing. So throughput influences safety a great deal. Transitions of care then I believe are also a source of risk to us, and as many of us know, as readmissions are something that we all measure and try to reduce, managing our transitions of care is a part of the organizational skill set that we have to have. And we in Maryland, as I mentioned, are slightly different from the other 49 states. And we've had a CMS demonstration grant here at Johns Hopkins aimed at reducing hospital readmission and emergency department use through a series of interventions of readmissions, prevention bundles, behavioral health interventions, etc. And indeed, we have had some real success on this early on that I'll share with you. Again, under the heading of transparent metrics, these are the state-reported metrics of readmissions at our 4 Maryland hospitals. And what you can see is observed and expected rates for 2013 and 2015 for each of our hospitals. Now these are readmission rates at all hospitals in the state of Maryland, not just the same hospital. So they will be a little higher than our same hospital readmission rates. Many of us probably know our same hospital readmission rates. Many of us may not know how many of our patients are readmitted at other hospitals. These tables show that if you pick it on the Hopkins Bayview, my hospital, we were at 17.42% in 2013, and we came down to 15.78% in 2015. And you can see the expected rates were at 14.8 and came down just a little bit at 14.72. And so that observed to expected ratio went from 1.17% down to 1.07%. And we had a statewide target of 1.06% where we almost achieved that, not quite. But we were very proud to be reducing our readmissions in the range of 9% through some of these kinds of interventions. And so again, managing our transitions is yet another source of safety where there's that opportunity for a better and improved transition for our patients who are outside the walls of our hospital. Now I want to switch gears, though, to patient and visitor safety. The slide you're looking at here is a vigil for those of you who are around when the Virginia Tech shootings happened. It was a horrible day in U.S. history, and one of the things that many universities did in response to that was assess their own readiness for an active shooter or an event like that which occurred at Virginia Tech that day. And we at Hopkins Medicine did indeed build some functions into our organization that would help us with that. We met with our local law enforcement leadership. We developed an emergency alert system that I'll show you an example of in a minute, and coordinated our responses and policies across the organization to make sure that we could be ready that in the event something like that happened. And it turned out to be unfortunately prescient, because we at the Johns Hopkins Hospital actually had an active shooter in 2010. Some of you may remember this, that we had a horrible situation where a family member, distraught over his mother's situation and probably many other things in his life, came into the hospital with a gun, shot the physician in the hallway, then went into his mother's room, barricaded himself, and eventually killed his mother and himself. And it was a tragic situation that sort of all of us could only imagine in our worst nightmares. We were pleased, if it's possible to be pleased, that we were pretty well prepared for this, in the sense that some of those steps we took since Virginia Tech did enable us to respond certainly much better than we would have. And so what you're seeing on that, the old-looking BlackBerry there, is the actual Hopkins alert that went out just within moments of the event being called into security. And so upwards of 25,000 people are able to get these kinds of alerts in real time. And so when you think about safety, what are you doing to protect your staff, patients, and visitors? This was something that we did and need to continue to do, unfortunately, to be as ready as we can be in that situation. We have an online training for this now that everybody is required to take as a part of their employment with us, and this is just a snapshot of that screen where we encourage people to go and do these things online. This is the active shooter training module. We also had one of our own staff attacked and beaten by a patient at my Hopkins Bayesian Medical Center. This was now about a year and a half ago. And again, this event probably happens in other hospitals with some routine. This was a nurse on a general medicine unit caring for a patient with a significant medical and substance abuse disorder issue. The patient became distraught and eventually attacked the nurse and beat her fairly severely before security arrived and established control. She was psychologically and physically injured. Thankfully, she's doing well now, but it was the kind of event that we all had to ask, what could we have done differently, and what could we have been more prepared for in that regard. It turns out that we did have a program on crisis prevention education that had been in place for several years before that, but that program had been focused on the units of psychiatry and the emergency department and had not yet been spread to our general medicine floors. And so as I'll show you, we had sort of group 1 modules of crisis prevention training that were required by CMS, COMAR, and the Joint Commission for our inpatient psychiatry, ED, and outpatient psychiatry staff and residents. And that's an annual as well as upon employment kind of training. We do have some Group 2 modules that are for non-mandated areas, but we identified the need to treat some of the medical units in this category, including that medical behavioral unit I mentioned to you earlier in the Falls area. So lots of different modules that we provide training to different groups on, as you can kind of see. And again, I won't read each of the details on there, but you get a feel for what's there. Since that event happened, we then established another crisis prevention education coordinator because we simply didn't have enough bandwidth to expand the training to these other medical floors, our medical A and medical B and that CBMU unit. Those are general medicine floors with patients who, in the range of 40 to 45% of the patients on those floors are estimated to have a substance abuse or mental health condition. And so since that event, we have greatly expanded the training that we provide. We have put in more panic alarms at different parts of the hospital and have measured more carefully our security response times. And these are the kinds of steps that we're taking to ensure the safety of our staff. And so staff safety, I don't know if any of you have been to ThedaCare. ThedaCare is a terrific health system in Appleton, Wisconsin, known for having very in-depth implementation of lean management techniques. And a number of us went there to look and see what they did. And this image here is just from their, what they call their True North metrics wall, where in their management meeting room, they actually put a little silhouette on the wall for every staff person who experienced harm in the last month, and they put their name underneath it. They keep it small so that we can take this picture and not divulge the privacy. But the concept is to have a very almost sacred pact with your team that your safety matters greatly to us, and that we are going to measure it, improve it, and treat it like any other safety event that we would for our patients. And we think that's part of engaging everybody in the culture of safety. And we were very struck by how overt ThedaCare's metrics were, and we are beginning to do something similar here at my hospital. And then I just want to kind of close with a more broad comment about kind of our risk to society. And I come at this because I was trained in public health. And as you know, the public health approach to things is sometimes different from the approach in an acute care hospital setting. Most of us in an acute hospital setting think about the things we can control and don't think about the things outside of our control. But what I'm showing you here is an image on the left side, a publication of a South Korean experiment in thyroid cancer that I'll talk about. And on the right, an image from Flint, Michigan, which I'm sure many of you are quite familiar with as a source of real challenges with respect to their water supply. On the left, what happened in South Korea was in the late 90s, there was a program to incentivize the screening for thyroid cancer via ultrasound. And so physicians were encouraged to screen for thyroid cancer ultrasonically and were paid reasonably well to do it. And so what the graph here shows, and this is a New England Journal of Medicine publication, was what happened, that indeed they did discover a lot more thyroid cancer over time. That these thyroid cancers were likely clinically inapparent up until this point, but when we introduced a more aggressive screening, we saw many more patients diagnosed with thyroid cancer. But if you can make out the tiny dotted line very close to the zero at the bottom, that's the number of people dying from thyroid cancer. And you can see that mortality rate, the thyroid mortality count is basically unchanged. And so what's happened here is we have discovered a lot of clinically inapparent thyroid cancer that was never going to kill anybody. And in fact, what we've done is biopsy, remove, treat a lot of thyroid disease, and certainly cause anxiety, certainly cause some patient harm in the process, and certainly spend a great deal of society's money looking at that thyroid cancer without really much benefit at all in terms of thyroid cancer mortality. And so the New England Journal of Medicine authors who published this are clearly making the point that we have to be careful about, in a fee-for-service medicine world, which things we encourage and which things we do a lot of. And the idea that I'm proposing is that if we do too much of that work, if we do too much wasteful medicine that doesn't add value, we eventually take away from the money available for things much more basic like water in Flint, Michigan. And I believe that when you see a situation like Flint, Michigan, where they were clearly trying to save money, changing their water source from one to the other, it certainly begs the question, have we put too much pressure on ourselves if we're willing to take a risk like that with the water supply? And so I, as a chief operating officer, think that at some level we have a responsibility to think about how we expend society's resources on our health services, and do so in a way that we think represents a responsible practice of medicine over time. And I just wanted to put that out there for just a little bit of food for thought, because it's a little outside the boundaries of normal safety. But intruding lead into the water for children in the community is a pretty substantial safety risk by most measures. So I'll stop there and just summarize a little bit, because I've touched on a number of issues, but I just want to come back to, as hospital operations people, patient safety of our patients is clearly at the heart of what we do and has to remain the front and center focus. But the close analogy to that, the close partner to that, is providing a safe care environment and workplace which establishes that pact with our staff that we value your safety every bit as much as we value our patient safety. And we think that engages the staff to be productive and positive contributors to our safety culture over time. Conducting the responsible practice of medicine is clearly in our responsibilities at some point, and I just put that on there to make sure that we all consider that as a part of being largely fee-for-service providers. And then I put that watch numerators and denominators on there because if you think about that South Korean example I showed you, a cynical policymaker could correctly declare that the thyroid cancer mortality rate has dropped in South Korea. And that's because the denominator has been greatly enriched with so many more cases, yet the numerator of deaths has remained essentially unchanged, and therefore the rate has dropped dramatically. Those of us who talk about these issues in our hospitals need to be very savvy about these things. I'm sure many of you have heard how sepsis mortality rates and sepsis readmission rates have been dropping greatly. But many of those have been dropping greatly because we have been more aggressive at documenting patients with sepsis. And again, we've enriched the denominator of patients who have sepsis, and yet our numerators may not be declining as quickly. And therefore, we can declare that our mortality and readmission rates are dropping, but we need to be very cognizant of what's happening to our actual counts of those events as well. And so those are just some thoughts that I bring as a Chief Operating Officer, and I remind you that it's about the current patient, it's about the next one when you think about throughput, it's about our team members. Do we have a sacred pact with our staff to protect their safety, their family members and our family members, our patients who are transitioning out of our care and into the community? We have a responsibility to manage that correctly. And then I put the future patient. What is our responsibility to our community for its overall health, and what role can we play in communicating those risks and opportunities as responsible providers? So I think I'll stop at this point and give it back to Lauren and Sally and invite questions. And I hope this has been helpful and useful.
Dr. Reuland, thank you so very much. We are really, really grateful for that very comprehensive view of safety, and I think you really made some important points about really a definitive and encompassing definition of safety, because we clearly can't achieve, I think, what we want to achieve as far as patient safety goes without ensuring the safety and high-quality work environment for our team members. I think you hit that right on the nose. What I'd like to do is ask Antoine, our operator, to remind our participants on the line about how they can dial in and ask a question or provide any comments or feedback to some of the points that we just heard. Antoine?
Ladies and gentlemen, if you'd like to register a question, please press star, followed by the number 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound key. One moment, please, for the first question.
And just in case folks don't feel comfortable asking their question via phone, just a quick reminder that if you're joining us on the online portion of the webinar, you can always type your comment or question into the chat box on the left-hand side of your computer screen as well. You know, as folks are putting in their questions or coming up with some of their comments, Dr. Reuland, one of the things that I think we get a lot of questions about often from different executives and patient safety leaders that we've had the opportunity to work with is really around how do you engage medical staff. So I'm curious, from your point of view, how have you partnered or worked with your medical staff to really engage them as champions of this kind of more comprehensive view of safety that you shared with us?
It's a great question, and it probably varies greatly depending on your own situation. We are in a situation where we have a closed staff in the sense that all of our physicians are School of Medicine full-time faculty here at Johns Hopkins. And that actually enables us to do a few things internally with the governance structure. So if you go to the highest level of our organization, our dean and CEO is the dean of our School of Medicine and the CEO for Johns Hopkins Medicine, which includes all of our hospitals. And so that position has the ability to require department chairs, physician leaders to engage. So there's a structural opportunity that may be a little different from hospitals who have voluntary physician staff. So we have that, I'll call it an advantage in that regard. But I think generally speaking, you don't need to browbeat people into this. Most clinicians, when given good information about the performance of their system, respond very well and engage pretty readily. So my advice is generally providing really good information about what actually is happening and as much information as you can about how that compares to benchmarks outside of your organization is a very powerful motivator. So when we look at surgical site infection rates, it's not difficult to engage our surgeons in that discussion if you show them that their rate is higher than somebody else's. And in fact, at Hopkins Bayview, a couple of ours, in about 8 different areas, 3 of them were higher than other areas. We're now in a place where all of them are operating below their observed to expected targets. And just by sharing those data very transparently and openly, I think most caregivers will want to do the right things when given the right information. So somewhere between giving them the opportunity to do it and requiring them to do it has been our success, but mostly it's been giving them the opportunity to.
Fantastic. And Antoine, do we have any questions that have come through on the phone line?
Oh, and there are no audio questions.
Okay. Well, we'll give folks just a couple of more minutes here. Again, if you'd like to ask a question or provide a comment, provide your perspective on perhaps how you have worked to develop some of these cultural components of a culture of accountability in your organization, we'd love to hear from you. Again, that's *1 on your telephone if you'd like to make a comment or provide a question, or you can also enter those in the chat box. So, Dr. Reuland, one of the things that I thought you brought up early in your talk, which was really interesting, you mentioned it briefly that you had invited a board member to team up with you and participate in one of your CUSP teams. I'm curious if you could talk a little bit about the connections that you've made with frontline teams and the time that you've invested in participating as an executive for a CUSP team and doing executive rounding, and what role that plays in really your approach to patient safety and this kind of culture of accountability.
Well, you know, one of the things that I pride myself in is spending a lot of time on the floors and the units of the hospital. I know it's kind of cliche to say management by walking around, but I do try very much to be out and about myself, so that the staff are comfortable sharing with me what's really happening and happy to engage me in the solution. So an example is late as last Friday evening, I was rounding in our NICU. I just popped up there because I was introducing one of our new administrators to some of the team up there. And I walked in, and some of the nurses were gathered around a computer, and they were concerned that they had sent a result down to the lab. They had sent a sample down to the lab on one of the the babies in the unit there, and the results hadn't come back yet, and they were on the phone with the lab trying to figure out why they couldn't find those results. It turns out they decided to draw another sample, which is not ideal, but they decided to do it to make sure that we could get the result we needed. And I took the opportunity to actually walk down to the lab to see that the sample was received and sort of watch what happened down there. And I was pleased that by the time I actually got to the lab, the result was already posted and done. And so when I went back to the NICU, they of course thought that I had personally done that, which was not correct. But it's that kind of presence that you're engaged in the most basic things that they need every day, and helping them understand how you can help them, and helping them tell you the things that you need to know about that don't flash up on a report every day. I think as a leader that's critical for me to do. And I am the safety executive on 5 different units now: our emergency department, the prep for the ORs, the PACU for the ORs, the SICU, and the burn unit.
Wow, for 5 different units. How do you find the time?
Well, I think you have to make the time, really. I think it's at some level you just need to make the time that if safety really does matter to you. And my rounds are not always just about safety. When I'm out and around, obviously when I'm in a safety rounds meeting, we're talking just about safety issues. But my presence on the floors is about engaging the team in safety, service, and all the things that we do as a hospital. So I'm not sure how to answer other than you make that time.
Make it the priority, sure. And I know that you talked through some of the kind of challenges along the way, but I'm curious from your perspective, what has been perhaps one of the more difficult elements of developing this culture of accountability, this culture of safety, this kind of shared mindset that this is part of just what we do here at Bayview?
I think the metrics of today are still evolving and rudimentary at some level. And so you remember some of the early core measures of the antibiotics in the emergency departments, that some of those core measures our care teams would find inappropriate to follow in some cases. And indeed, some of those core measures were changed later on, so that trying to engage a care team in something that they don't fundamentally agree with has always been a challenge. So I think giving them the idea that we don't fully control all the measures that are out there, and that in some cases we'll have to decide whether we're going to comply with a measure that we don't fully agree with, or if we're going to take a stand and decide we're not going to. But those conversations are challenging because oftentimes it's really just resistance and not necessarily evidence-based. But in some cases, our care teams have been right, and there is real evidence to support what they do. And striking that balance of not just discarding all of the measures as nonsense, yet also being willing to be critical of the measures has been an important balance to establish.
And that's a difficult thing to really establish a balance around, given that I think that is probably one of the more common pieces of pushback or concerns that we hear time and time again with frontline staff around some of the metrics, and rightfully so. Some of them are probably valuable, and some of them could use some improvement.
Yeah, absolutely. And hopefully what they cause you to do is look at your system methodically and with data, and that you can, from a position of strength, decide how you want to adjust your system, as opposed to from a position of ignorance.
Absolutely. Antoine, just to check in, any questions from the audience so far?
There are no audio questions.
Okay. So just one last question for you, Dr. Reuland. I know we're coming up here on the end of your time, and we've been so grateful for the amount of time that you've been willing to spend with us today. But from your point of view, I know you highlighted some of them, I think, at the end of your talk by bringing in some of the public health perspectives and really thinking about the value of care and linking that to patient safety. From your perspective, what would you say are some of the major challenges ahead on the horizon for other COOs and other executive and physician leaders who are really committed to building this culture of safety?
Oh boy.
Sorry, that's a big one, I know.
How long do we have? No, I think, you know, I sort of think that the direction we need to go is not to be satisfied with, if you think about it, it's a pretty low bar to say that we as a healthcare organization won't harm you while you're in our midst. That's, you know, some of our quality measures today that they're great. They're 30-day readmission rates, they're surgical site infection rates, and the process measures that we all know as the core measures and things like that. They're very good, but if we were in the auto industry, they might be the equivalent of Toyota declaring victory that they had not dropped your car on the assembly line and that you had safely driven it home, and saying that that was good enough. And we all know that what people come to us for is for their overall health status and their overall quality of life. And so we need to learn not to just ask, did we infect your joint when we replaced it? But we should be developing the quality measures that say, are you able to walk your dog 3 years after the surgery, or do the things functionally that you wanted to do? And are we measuring the longitudinal effects of what we do? I think those are really important, where safety evolves into quality in a kind of a blurring of those lines over time. We still have plenty of harms to manage internally, but I think what I was alluding to with that South Korean example is there are lots of ways that we can spend society's money. We need to be thoughtful about those things which will improve the health of as many of our people as we can. In some cases, as we are shifting to population health, we need to think about that. So it's a complicated question, and if I gave it more time, might give a better answer, but those are just some initial thoughts.
Well, Dr. Reuland, thank you so very much for sharing your thoughts with us today. I think that there were some really fantastic insights and examples that you shared, and I know many of our participants took away some really important things today. We're really looking forward to continuing the conversation. If any questions do come up after the webinar, if you wouldn't mind, we'd love to share those with you as well and gather some of your insights.
Of course, I'd be glad to.